everyone, and welcome to our video. Our video is over complex regional pain syndrome. My name is Emily Tripp, and also presenting are Taporia Brown, Hannah Adams, and Hannah Smith. So what is CRPS? According to the National Organization for Rare Disorders, CRPS is a condition where a person experiences pain that is disproportional in response to a stimulus compared to a normal response or amount of pain that is typically experienced. There are three types. Type 1 is 90% of cases where there is no nerve injury or damage present. Type 2 is where nerve damage is present. And the third type is when a person has remission of some features. Type 3 applies to patients who have previously met all of the criteria for CRPS, but in the present moment only have some criteria because of possible improvement. Signs and symptoms include deep pain and a warm, red, and swollen limb initially. The skin can be thin and shiny, and the hair and nail growth may change in the affected extremity. Motor impairment can be due to pain and edema. Lastly, there can be pseudomotor dysfunction, which is changes in sweating of the limb. This slide we can see on the chart visually just the symptoms of CRPS, and then the pictures are depicting the symptoms as well, so you can see that the limbs appear swollen and the skin may be discolored or a red color. The causes of CRPS are unclear, but there may be some factors that contribute to the condition. Immobilization after an injury may lead to increased sensitivity to pain or changes in temperature of the limb. CRPS may also involve the sympathetic nervous system. Initially with the syndrome, the sympathetic nervous system activity is decreased, which may contribute to the presence of redness and swollen limbs. The sympathetic nervous system is involved in pain, which may play a role in pain with CRPS. And lastly, inflammation and pain-enhancing substances, they have been found to be higher in patients with CRPS. An overall diagnosis of CRPS is typically assessed using something called the Budapest criteria. There are 4 components to this criteria. The first one is continuing pain that is disproportionate to the stimulus provoking the pain. Second, the patient has to report 3 out of the following symptoms: sensory, which would be increased sensitivity; vasomotor, which is temperature or color changes in the skin; pseudomotor, which is sweating changes; motor would be impairment, and also trophic changes, which would be changes in the skin, hair, or nails. The third criteria is that in previously mentioned categories, a healthcare professional must observe at least 2 out of 4 of these signs. And the fourth and last component is that no other diagnosis explains the symptoms. The prevalence of CRPS, it's more common in women, 3 to 4 times more prevalent, and it's more common in adults than children and adolescents. But if the onset is in children, it's typically during adolescence, and the onset for adults varies. It's also most common in European descent, and in the United States, for CRPS type 1, 5.46 out of 100,000 people a year have the condition, and about 200,000 people suffer from the syndrome each year.
Due to CRPS being such a debilitating condition, it can have a big impact on society and how a person functions in everyday life. An article by Kemmler and Fernie stated that CRPS has been found to greatly affect the household income due to decreased ability to work. Another article by Johnston, Devon, and colleagues stated that individuals who live with CRPS generally have a poorer quality of life and may have a higher risk of suicide than people with other chronic conditions, and CRPS results in more disability and a higher service use than people living with other pain conditions.
Some common risk factors for CRPS include, but are not limited to, forceful trauma to an arm or a leg, surgeries, heart attacks, various infections, and psychiatric diseases such as anxiety, mood disorders, and insomnia. The symptoms of CRPS can be made worse by anxiety, depression, or anger.
CRPS can impact many occupations. Some examples are ADLs, IADLs, specifically driving and community mobility, health management, and home management, as well as rest and sleep, work, and social participation. Occupations such as these are primarily affected due to the severity of pain that the individual is experiencing.
Some ways that OTs can help clients with CRPS include improving their range of motion, desensitization, reducing swelling, decreasing muscle guarding, improving functional use of the extremities, and suggesting adaptive equipment. Adaptive equipment could be suggested through a home assessment by the OT.
For the assessment and outcome measures, the initial evaluation should include the date of onset of the original injury. This is helpful in determining which stage the client is in, and the date of onset of the CRPS symptoms. Next, the practitioner should perform a thorough visual inspection of the affected area. Establishing a baseline for strength and range of motion are next with respect to upper and lower extremities. If lower, evaluate the distance able to walk and the client's need for an assistive device, as well as their hip, knee, and ankle range of motion. If upper, establish a baseline for grip strength, pinch strength, and shoulder range of motion. Next, the practitioner should objectify swelling, respecting the patient's pain. The practitioner could perform volume displacement or take measurements of the affected side compared to the unaffected side. From there, the practitioner should define the functional limitations and documentation, and lastly, educate the client on CRPS and the treatment process. 2 patient-reported outcome measures used for CRPS include the Brief Pain Inventory long form, which allows the patient to rate the severity of their pain, to which degree the pain interferes with their quality of life and ADLs. The McGill Pain Questionnaire assesses the quality and intensity of the pain and is a multifunctional measure that has 3 components: sensory intensity, cognitive impact of pain, and emotional impact of pain.
Interventions that have been researched for CRPS include stellate ganglion block, mirror therapy, desensitization, spinal cord stimulation, and virtual reality. A study by Chang and colleagues looked at the association between pain reduction and temperature difference between the contralateral and affected limbs of 318 patients who suffered with CRPS through the use of stellate ganglion block. The results showed that there was a pain improvement of more than 50% in 155 patients, and the majority of the patients were found to have more than 50% pain relief for 1 to 4 weeks or longer. A study by Caccio and colleagues compared the effectiveness of mirror therapy on function of the upper limb and pain in patients who were diagnosed with upper limb CRPS post-stroke. The results found a decrease in pain at rest, during movement, and when experiencing brush-induced tactile allodynia when mirror therapy was implemented. A study by Conan and colleagues focused on a female who presented with CRPS symptoms of the right forearm and wrist. Bilateral desensitization was simultaneously implemented on her unaffected arm as well as her affected arm. Research showed that through the use of this bilateral desensitization, CRPS symptoms reduced. Hoikinen and colleagues focused on the effects of spinal cord stimulation on chronic neuropathic pain. The electrode was implanted into the epidural space of the spinal canal in 35 patients and were followed up on 8 years later. Results showed that at least 70% of the patients continued to use SCS to help with pain reduction. Lastly, a study by Chow and colleagues analyzed the effects of virtual reality on pain levels of upper limb CRPS. 6 subjects participated in a virtual simulated kitchen that included object manipulation with virtual hands. Subjects performed 10 sessions that involved performing daily tasks and visualization exercises. The results of the study showed that the subjects had reduced pain and improvement in daily function.
All right, we'll start with, how did you become diagnosed with CRPS?
Okay, so how I got initially diagnosed, I had a back surgery from an injury, and I had to get my L4, 5, and S1 fused. The accident, the surgery didn't go well, and I ended up getting symptoms from the first surgery. And I went to my surgeon, and he had a small knowledge of kind of what I had. We went back for exploratory surgery, and before the second surgery, I remember saying to him, I hope we can get rid of this burning on my leg, because it was terrible. And he's like, don't count on it. And that kind of stuck with me. And then after that, he sent me to a doctor, a specialist at CDH, Central DuPage Hospital, an anesthesiologist specialist, and he put me on a series of injections, 6 injections. I only lasted through the second one. Nothing worked. What really set it off was my first visit with the specialist after my second surgery. I took my shoes off, and my right foot was probably the color of my shirt, or probably darker. And I've got pictures, and that really showed me, because because of the CRPS, I have to always wear warm clothes. So I always wear like wool socks and stuff. So my socks are always covered. So I'm never paying attention to my socks or my feet. So when I went there, I'm like, oh my God, my foot is just magenta compared to the other one. So that's when I really got diagnosed. Because from there, that was another stepping stone to, this guy said, look, there's nothing I can do for you. I want to get another opinion. So he sent me to a neurologist at CDH. She concluded, yeah, you've got CRPS. They sent me to a specialist down in the city, where I've been for probably 4 or 5 years now, 6 years now. So it's been a journey.
Wow. And so the next question we have is, can you talk a little bit about like the symptoms that you've experienced maybe at the beginning, and maybe what you experience now?
Sure. The first symptom I experienced was after the first surgery. I was sent to a rehab center, and I was actually doing so well, they were going to send me home early. And one night I got up to go to the washroom. Nurse came in to help me, and I got up, and I felt like someone shot me in the back of my leg. And I immediately had to sit down, and it was the weirdest thing. And they told the doctors and specialists. And the next morning, every time I stood up, it was just the craziest thing. It was just a gunshot. They sent me over to CDH because they thought it was a blood clot in my leg, but it wasn't. So they couldn't do anything for me at the therapist center. So they went on my way, and then that symptom went down to my leg, created all the other burning in my foot, and it goes from burning in my foot, numbness. I get what I call a spoon dig in the arch of my foot constantly. I get a needle injection, but it feels like in my big toe. I get burning on the top of my foot. I get burning on the right side of my shin. I have to use a cane. But those are basically from the CRPS, my pain. And my back is from the CRPS and all the surgeries I've been through. That pain is what knocks me out. I can't recreate it. It happens all the time. And it's just, what I compare it to is when a dentist hits a nerve in your tooth, and kind of multiply that by like 100. And it's the craziest thing. And it happens on the right side and the left side, a couple inches lower from where my implants are at. Can't explain it. They don't know what it is. just a cycle. Every 3 months, I go to doctors down in the city, and they put their heads together and try to figure out what they can do. So, but yeah, that's another thing. I can't, because of the pain in my foot. I cannot drive because with the CRPS, and you can't recreate it, any pain, because it's nerve related. The pain that shoots in my foot, since it happens so many times and I don't know when, I can't drive. I can only use my left foot. I have been trained to left pedal drive, so that's in the future.
So next question, how has having CRPS impacted your occupations? So like you said that you struggle with driving. Are there any other activities that you would say that you struggle with just due to the CRPS?
Yeah, I say, I guess my motto, I say, I don't know how my day is going to be until I look out the window. It's really weather related. CRPS, it really flares up due to barometer and humidity. But everything I do, from when I wake up in the morning, I go to bed at night, everything's slow. I have to slow down. Everything is low. Everything that I have to bend down for, pick up, is not enjoyable. Gravity is not my friend. What else did I have? It's just daily life. It inhibits me from doing my father duties and my husband duties. Like, I can't mow the lawn, I can't shovel the driveway, I can't, there's certain things I do, but it's really shut, my life down to. Now there's people far worse than I am. I've seen them. But it's slowed life down to, like, I keep saying, I live one life at a time. I mean, one day at a time.
Mm-hmm.
So, but it's all good.
If you're finished with that question, our last one is, what is one thing that you wish people knew about CRPS?
Yeah, that's a good question. I don't know what. I wish the medical field knew more about it, because it's still new. The doctors know more than the FDA is allowing them to clear. I've been told that there's medical devices that will help me with progression of pain relief, but it hasn't been cleared yet through the FDA. But it's kind of one of these situations that you don't know what it is. I guess you don't know what it is until you get thrown into it. It's like with Hannah. It's like she was premature. I mean, my wife and I, we had no idea what a premature baby was. I didn't even know the term premature baby until we had her. So I didn't know anything about CRPS. I didn't even know the acronym. I didn't even know what he meant until, I got it. But I was in. It made me think I was in.
Patient education is important for individuals with CRPS. It's important to get to know the patient well and to thoroughly explain to them what CRPS is and why they are experiencing what they are. Encouraging the client to engage in meaningful treatment activities is also important for their symptom management. Helping the client create realistic goals for themselves is important for the psychological aspect of CRPS. Finally, creating a home exercise program for the client and stressing the importance of completing the exercises as instructed is important for the client's overall progress with CRPS.
A home exercise program for those with CRPS typically involves range of motion and strength training. Based on research from Carlson and Watson, the stress loading protocol supports range of motion and strength training. This protocol is to begin respecting the client's pain and limitations and provide an increase in demand for sensory input of the affected nerves. Stress loading has two components, scrubbing and carrying. Scrubbing applies constant force through the affected area for progressively increasing periods of time without a break. A break in between reps could increase pain. It is best for the patient to be educated on resting in between sets. Carrying involves carrying a weighted object for increasing periods of time with the affected areas in order to provide load. Scrubbing and carrying can be applied to upper and lower extremities. Desensitization is the next step in this protocol and can be taught in therapy and exercised at home. Desensitization involves various textures or fabrics presented to the area, progressing from least to most noxious, consistent to intermittent applications in order to improve tolerance to light touch or pressure. After the initial phase of scrubbing, carrying, and desensitization, the home exercise program can be upgraded to focus on range of motion and strength training specific joints and muscles. Additional research on CRPS covers a range of topics such as dispelling myths, interdisciplinary management, and treatment options.